guys, welcome back to my channel Meddict-a Budding Doctor. In today's video we are going to discuss about rectus sheath. So what is rectus sheath? Rectus sheath is an aponeurotic sheath enclosing the rectus abdominis muscle and pyramidalis muscle if present on either side of the linea alba. It is derived from the aponeurosis of the flat muscles of the anterior abdominal wall. Now the functions of the rectus sheath. There are two functions: checking the bowing of rectus abdominis muscle during its contraction and hence increasing its efficiency. The second function is maintaining the strength of the anterior abdominal wall. Now with the help of this diagram, I am going to explain you the features of rectus sheath. The rectus sheath presents an anterior wall which is shown in green, and it also presents a posterior wall. It is marked here as posterior wall of rectus sheath. The anterior wall is complete and covers the entire extent of muscle longitudinally from the upper end to the lower end, and the posterior wall is deficient above and below, hence does not cover the entire extent of the muscle longitudinally. Above, it is attached to the costal margin, 7th, 8th and 9th costal cartilages, and thus the muscle lies directly on the 5th, 6th and 7th costal cartilage. Below, it presents as a free curved margin with concavity facing inferiorly, which is known as the arcuate line, as you can see marked here with the dot green line. This arcuate line is also known as line of Douglas. It lies between the umbilicus and the pubic symphysis. Below this level, the muscle directly lies on the fascia transversalis. One note we can remember is anterior wall of rectus sheath is firmly adherent to the tendinous intersections of the rectus abdominis, as you can see in the diagram. This wavy green lines, whereas the posterior wall is free from the muscle. Now we are going to discuss about formation of rectus sheath. The formation of rectus sheath differs from above downwards. The first is above the level of costal margin. Above the level of costal margin, the anterior wall is formed by the aponeurosis of the external oblique only, and the posterior wall is deficient, and the muscle lies directly on the 5th, 6th and 7th costal cartilages, as I mentioned earlier. Now between the costal margin and the arcuate line, the anterior wall is formed by the fusion of aponeurosis of the external oblique with the anterior lamina of the aponeurosis of the internal oblique, as you can see in the diagram. Whereas the posterior wall is formed by the fusion of aponeurosis of the transverse abdominis with the posterior lamina of the aponeurosis of the internal oblique. Now below the level of the arcuate line, anterior wall is formed by the aponeurosis of all the three flat muscles. One thing we can note here is the aponeurosis of the external oblique is separated, while the internal oblique and transversus abdominis are fused. Next is contents of the rectus sheath. The contents of the rectus sheath are as follows: two muscles, rectus abdominis and pyramidalis if it is present, two arteries, superior epigastric and inferior epigastric, two veins, superior epigastric and inferior epigastric veins, and 6 nerves. Terminal part of the lower 6 thoracic nerves, including the lower 5 intercostal nerves and some costal nerve. These are accompanied by the terminal parts of the posterior intercostal vessels. Now we are going to discuss the relevant features of these contents. The first is superior epigastric artery. It is a branch of internal thoracic artery which enters the rectus by passing through the gap between the intercostal and xiphoid slips of the origin of the diaphragm, and it passes deep to the rectus abdominis. The inferior epigastric artery, which is a branch of the external iliac artery, enters the sheath in front of the arcuate line, and these arteries anastomose with each other within the sheath and supply the rectus muscle. Next is superior epigastric vein. Superior epigastric vein accompanies the superior epigastric arteries and drain into the internal thoracic vein, whereas the inferior epigastric vein accompanies the inferior epigastric artery and drains into the external iliac veins. The intercostal nerves T7 to T11 pass from their intercostal spaces into the abdominal wall between the internal oblique and transversus abdominis muscle and run in this neurovascular plane to enter the rectus sheath by piercing the posterior lamina of the internal oblique aponeurosis. Within the sheath, they proceed forward deep to rectus muscle to about its midline and then enter the muscle and supply it, and emerge through the anterior wall of the sheath as anterior cutaneous nerves. Now we are going to discuss the clinical correlation of this topic. The first one is devarication of the rectum, that is separation of the recti abdominis muscles. The separation of the two rectus muscles usually occurs in elderly multiparous women with weak abdominal muscles. Multiparous means the woman who has given birth to at least one child. In this condition, the aponeurosis forming the rectus sheath becomes excessively stretched. Consequently, when the patient coughs or strains, the recti separate widely and a hernial sac containing loops of intestine protrudes forward between the medial margins of the recti. Now in this diagram as well, you can see the separation of the two rectus muscles. Next is hematoma of the rectus sheath. Sometimes the superior and inferior epigastric arteries are unduly stretched during a severe bout of coughing or in later months of pregnancy and ruptures if they are exposed to blunt trauma to the anterior abdominal wall, leading to the formation of hematoma within the rectus sheath. Clinically, it presents as midline abdominal pain and tender mass confined to one rectus sheath. Next is epigastric hernia. Plinia alba, a midline fibrous raphe, is formed by the interlacing of the aponeurosis fibers of the three paired flat muscles of the anterior abdominal wall. It extends from the xiphoid process to the pubic symphysis. Above the umbilicus it is wider, about 1 cm, and below the umbilicus it is very narrow. It becomes weak in elderly multiparous women as seen in devarication of the recti as well, and chronically ill children. When the intra-abdominal pressure is excessively raised, a small amount of the extraperitoneal fat may protrude through the upper part of the linea alba and eventually may drag behind it a small peritoneal sac which may contain a portion of greater omentum forming the epigastric hernia. So now this diagram represents epigastric hernia. So this is all for this video. I hope you found this video helpful, and if you did, you can press the like button, share my video and subscribe to my channel. So see you in the next video.